I'd like to request our chairpersons to introduce our speaker.
Dr. Vijesh Venugopal, MBBS, MD, PDCC and PGDM from USA. He is presently the Professor and Head Department of Anesthesiology, Deputy Dean, Central Research and Innovation Board, Academic Coordinator of KMCT Medical College, Calicut, Kerala. He has 22 years of experience as a cardiac anesthesiologist and his specific areas of interest are cardiac anesthesia, intensive care and perioperative echocardiography. So he has received KOPS award in pain category in SZISACON 2021. He is also the gold medalist in exit exam, PGDM from USA.
My topic is postoperative delirium and POCD in elderly patients. Aging population is a major demographic trend worldwide, and globally 50% of all elderly individuals are estimated to undergo at least one surgical procedure during their lifetime. The recent advances in medical technology and anesthetic care have made it possible for older patients with several comorbidities to safely undergo surgery. However, in the elderly, it's the central nervous system dysfunction that has been recognized as an alarming complication after both cardiac and non-cardiac surgery. So cognitive change that affects patients has been known probably since the last 100 years. And most of the clinicians are familiar with the clinical syndrome of delirium, which is a set of fluctuating changes in attention, mental status and level of consciousness, which is often seen after anesthesia and surgery. Aside from delirium, we have a large body of research which is examining POCD or cognitive decline after full recovery, which persists well beyond the expected pharmacological and physiological effects of anesthetic drugs. So why are we as anesthesiologists worried about this? Because if you look at the aging population in India, it is seen that the percentage of elderly population is set to increase from 7.6% to 20.6% by 2050. And similarly, during the same period, the octogenarians population will increase from 0.61% to 3.06%. So we are going to have a lot of elderly people coming up for surgery. And it is estimated that we'll have around 300 million elderly by 2050. That is close to the population of United States currently. And my home state of Kerala is aging faster than the rest of India. And we expect by 2050 to have 35% of the population of Kerala to be above 65 years of age. So that's what we are going to face. And we are all going to face a silver tsunami. So we should brace for the impact of silver tsunami affecting our operation theatres. The other concern that we can have is the long-term consequences of POCD. The long-term consequences are increased mortality, risk of leaving your job, and dependency on social transfer payments. So this is a study that was done in the European Union. And a study closer to home that was done in Sri Lanka showed that these patients, those patients who had delirium, they used the hospital resources more. So the idea is to detect it early and also to prevent it. Preferably, prevention is better than cure. And this is the first publication of POCD that was published way back in 1887 by George Savage in the British Medical Journal. And it was titled as Insanity Following the Use of Anesthetics in Operations. So this concept was known way back from 1887. But recently in 2018, certain new nomenclatures has been proposed. The term POCD is slowly going away, and right now it is referred to as a neurocognitive disorder. And based on the time period, it is given different names. So if you detect changes in the attention before a week, it is referred to as postoperative delirium, and after a week till 30 days, it is referred to as delayed neurocognitive recovery. And from 30 days to 1 year, if you find these developments, it is referred to as a neurocognitive disorder. And so that there is no confusion, in parenthesis, POCD is still continued. And beyond 12 months, no more it is called a postoperative, no more the postoperative element is involved. So this is based upon the DSM-5 criteria. Then there are a group of people who say that both postoperative delirium and POCD are same disorder, or they are somewhat similar because of the similar manifestations. But then there is a group of people who say that they are quite different. So that is quite normal. We will have disagreements. So coming to first the naysayers, they have some arguments in favor of saying that they are both different. So they have 4 arguments. The first thing is that they say that these syndromes are measured in different ways. Postoperative delirium is measured by instruments that evaluate attention, level of consciousness and disorganized thinking, such as the CAM score. In contrast, POCD is typically assessed by a drop in cognitive performance, and it is assessed by neuropsychological testing. The second argument is that these syndromes don't necessarily include deficits in the same cognitive domains, because all patients with delirium have attention deficits, while patients with POCD have deficits in the cognitive domain, that is in memory or executive function. The third argument is that these syndromes occur at different times. As I mentioned before, if it's before a week, it is definitely delirium, and beyond a month, it is POCD. And the fourth argument is for the naysayers is that there are very few, if any, human studies demonstrating that these disorders share the same pathophysiological mechanisms. Now coming to the lumpers who say that both of them are the same, they have also presented 4 arguments. The first thing is that several risk factors are common between postoperative delirium and POCD, such as a lower preoperative education level, poor preoperative cognitive function and depression. The second argument is that postoperative delirium and POCD are both associated with worse cognitive decline in the 3 to 5 years after anesthesia and surgery, with decreased quality of life and increased 1-year postoperative mortality. The third argument is that the animal studies raise the possibility of common pathophysiologic processes like neuroinflammation in both these disorders. And finally, the fourth argument that they have raised is that many patients with delirium develop postoperative cognitive deficit, and conversely, patients with POCD have had a delirium previously. However, this argument was laid to rest by a publication that came out in Anesthesiology 2019, where this was on successful aging after elective surgery study, which showed that both of these are different disorders. Now coming to the incidence, the international study on POCD published way back in 1998 in Lancet showed that in the first week the incidence is around 25%, whereas when it was checked after 3 months, it has come down to around 10%. Now what about the Indian data? We have a study from Mysore by Nalini Madam, which is published in IGA, which showed an incidence ranging from 12 to 7.5%. And when this group studied it later for minor surgery, they found that the incidence drops down to 9.7%. And they pointed out that they believe that the longer hospitalization in the first study was a major risk factor for development of POCD. What about emergency surgeries? In emergency surgeries, as per the Journal of American College of Surgery, it was seen that the incidence of delirium was around 26%, and if the patient developed delirium, they had an increase in the ICU admission as well as intubation and length of stay in the hospital. Now the next confusion is whether it is general anesthesia or regional anesthesia which contributes towards the postoperative cognitive dysfunction. But this study showed that there was no significant difference between the incidence of cognitive dysfunction at 3 months either with general or regional anesthesia. Later, a meta-analysis showed that it was regional anesthesia which is better and which prevents POCD. And this controversy is still raging, and this is a systematic review coming out from China which showed that it was only on the first and the third day that the postoperative delirium was higher in patients who underwent general anesthesia, and this difference was not seen on the 7th and the 7th day, after the 7th day, both after 7th day and at the end of 3 months. And a larger study which was published in IGA, around 2,500 patients again also showed no difference between, they suggested that general anesthesia does not contribute to POCD. Now coming to in general anesthesia itself, whether it's the intravenous or the inhalation anesthesia which contributes towards the postoperative cognitive dysfunction. And it was found that the TIVA has a protective effect, and the inhalation anesthesia is the one which causes more of POCD. Then coming to the depth of anesthesia, this is another trial that was published in the Brain and Behavior, where they showed that patients who had a who had a greater depth of anesthesia, whose BIS was maintained between 40 and 50, they had an increased incidence of POCD. So what they suggested is you should give adequate depth of anesthesia, not put the patient under too deep anesthesia. Now coming to the short and long-term relationship, you can see that initially once the patient, if you look at the second part, there you can follow my arrow, you can see that the patient, if the patient has delirium, there is a drop in his cognitive performance at 1 month, and it recovers slowly. And then these patients who had delirium have a biphasic response, and by the end of 1 year they have early onset dementia, and this is not seen in patients who do not have delirium. So there is a biphasic response. Now there are certain biomarkers, and MRI has also been proposed to investigate these changes, and the apolipoprotein E has been implicated as the gene that transcripts for this apolipoprotein E in Alzheimer's disease. So a lot of studies have seen whether the cognitive dysfunction can also be attributed to this gene, but we have studies which have not shown any association by McDonough as well as Albitstrom. However, Kai showed that in patients who underwent inhalation anesthesia, the apolipoprotein E4 had a strong association for the development of POCD. And the apolipoprotein E epsilon 4 allele was shown to have a significant association for POCD risk. So a lot of studies are going on to find neuroinflammatory markers. Then coming to MRI, you have a lot of newer modalities like the functional MRI, which can detect these changes in the brain. Now, as an anesthesiologist, what is your role in preventing this disease? Well, you can have preoperative interventions that you do. You can avoid perioperative polypharmacy. You can avoid prolonged fluid fasting, even though the present concept is to have just a 2-hour fasting, but still we tend to keep patients more fasted. That should be avoided. Comprehensive geriatric assessment should be done, preoperative and pain management. Now, this is the present level of evidence of intraoperative delirium risk reduction. You give good pain relief, dexmedetomidine, preoperative comprehensive geriatric assessment, avoid prolonged preoperative fluid fasting, and avoidance of intraoperative benzodiazepines have good evidence to show that it can reduce the cognitive dysfunction. Now coming to the post-operative management, non-pharmacological interventions definitely can reduce delirium, like giving them their eyes, the spectacles, hearing aids, and giving them good sleep cycles is also going to be of major help. So these are the 6 proven strategies to prevent delirium. You can keep on stimulating the mind of the patient, enable them to move early, sleep well, give them their spectacles as well as the hearing aids, keeping them hydrated and giving them good nutrition. So this is a takeoff from the ABCDEF ICU liberation mnemonic, where this is just ABCDE. So you have awake and breathing coordination, you choose light sedation and avoid benzodiazepines, have regular delirium monitoring and management, and early mobility and exercise will help in delirium prevention. Always remember the 4 M's of age-friendly care, that is, remember what matters. Preserve and motivate mobility, optimize medications. There is a Beers criteria which show potentially medications which should be avoided. And you should also assess and promote mentation. Now this is the recently published 2023 updated Beers criteria, where they have shown a lot of drugs which should not be given. A very busy slide, so I've just taken down what are the major things. Promethazine, diphenhydramine, benzodiazepines, meperidine and metoclopramide should be avoided in elderly patients above 65 years of age. We have the hospital Elder Life program, which is an interdisciplinary model of care where the volunteer who is elderly life specialist, geriatrician and an elderly life nurse specialist also, they coordinate and treat these patients. And this has also been shown on studies to benefit patients and prevent delirium. So what are the best practices based on the Brain Health Initiative? Preoperatively, a baseline cognition should be objectively evaluated with a screening tool in all patients who are above 65 years of age, and you can use any of these. And intraoperatively, the consensus statement is anesthesiologists should monitor age-adjusted end-tidal MAC fraction, strive to optimize cerebral perfusion, and perform EEG-based anesthetic management in elderly patients. So the main things are avoid centrally acting cholinergics, avoid relative hypotension, maintain normothermia, monitor age-adjusted end-tidal MAC fraction, and use EEG-based intraoperative brain monitoring to titrate anesthetic administration. So these are the drugs that we should try to avoid, especially the benzodiazepines, the antispasmodics, the central anticholinergic effects are very important that should avoid. You should avoid metoclopramide because it has extrapyramidal effects, and metpyridine. And postoperatively, you need more studies to evaluate the efficacy, feasibility, and cost effectiveness of various strategies to assess short-term and long-term cognitive outcomes. So this is basically what you should do. You should identify the high-risk patients, get a cognitive testing, identify them. You have to optimize any chronic disease, have a pharmacy review, hearing, visual, and other functional aids should be provided. Optimize these patients, get a consent that these neurocognitive disorders can occur, and provide them with adequate analgesia, and always remember that prevention is better than cure. I would like to conclude by saying that postoperative neurocognitive decline is a meaningful concern to patients and represents a significant and expanding challenge to healthcare. The best practices and interventions can begin before surgery and extend well into the recovery period. To be most effective, these strategies require family engagement and the involvement of an interdisciplinary healthcare team and comprehensive systems of care. Thank you.
Thank you, sir, for such a wonderful and excellent presentation.